We are live now. You can start. Thank you.
Good evening, everyone. I'll be presenting long case for today's Thursday clinic. My name is Dr. Shailja Chavan. 3-year, 11-month-old girl, second by birth order, born of third-degree consanguineous marriage, resident of Vadala, hailing from Bihar, Muslim by religion, Sikh by community, brought by an informant being mother with a chief complaint of fever since 3 days, which is resolved since last 1 day, weakness of right upper limb since last 1 day. Even interfebrile period, child became febrile after 3 days of fever. Mother noticed that the child is not lifting her right upper limb after waking up from sleep. There was difficulty in lift of loose stools, no history of recent vaccination, no history of Cox or Cox contact, no history of similar complaints in past or family. Past history, there is no history of past admissions. ANC wise, patient was registered. Mother took supplements, 4 UHS scans which were told to be normal. There was no history of leaking or bleeding PD, no history of fever with rash or thyroid disorders in mother. Birth-wise, the child was mid preterm, normal vaginal delivery. Done suggestive of biventricular hypertrophy, neonatal pH, serial scans were done which were told to be normal. There was no O2 support required. Patient was discharged after 15 days. Consumes mixed diet from family pot. There is calorie deficit of 300 and protein deficit of 6. Family history is gross motor-wise child up to 1 to 10. Socially, child can match colors, shows interest in sports. Each child tells stories and narrates events also.
So what do you make out of the fever? 3-year-old with 3 days of this kind of fever that's described there. So what do you make out of that?
Fever was present at start of illness, so maybe the contributing factor to the weakness of upper limb maybe it was fever.
That we'll see. See, for this fever. That fever for 3 days, correct? Then weakness, fourth day. So if this child would you have thought?
Uh,
What does the fever look like? That's what I'm asking.
Maybe I would have thought of monsoon related illness. There is no associated cough and cold also, but fever is there.
So just fevers there. So monsoon related illness means what type of illness? Viral infection, bacterial infection.
Infection, sir.
Okay. So anything odd for a viral infection?
Yeah, it's not. There is no system, not much.
Rings a bell. Okay, why is this only fever? Anything else? You said it is associated with chills, you said, no? So does that mean so Rigors is different, but yeah, usually higher fevers come with chills. Then what else does it mean? Does it have any localizing value? Will you call it viral or bacterial based on the chills? UTI has chills. Then liver abscess has chills. Then malaria has chills. Then does influenza have chills? Typical influenza A. Yes or no? Yes. Viral or bacterial. Right? Now what else?
Bad period. Tells you more about viral. Actually, the last.
Means, for example, I'm saying, suppose there was cough, cold, body ache, headache. All these are positive towards viral. That is one way to think. And one way is there anything negative towards something? So what is there in this story which tells you that this is negative for a bacterial infection? So getting my point? And, and, and no localization till the third day, right? So everything you have to club together, right? So you are saying this is not bacterial for all these reasons. Then you are saying it's not viral because there's no polysymptomatic. So you start wondering what this fever. So, okay, now next day, it's on this slide, sorry. So where is the anatomy of this problem? It's weakness in one hand. So what is the first immediate question that should follow? How common is monoplegia? Not common, right? So most cases of monoplegia are actually hemiplegia or hemiparesis. Okay, where the involvement what was the leg involved? No. So the child was walking, doing everything. Okay. Then uh, so where is the anatomy? Is it spinal cord or is it central?
Manifested as hemiplegia or paralysis or something like that. The other thing, it's spinal. It is spinal.
Localized involvement is there, so lower motor neuron had been one.
You are saying that because it is so localized, there are higher chances that it may be lower motor neuron, right? So, if so, then where in the lower motor neuron? Means which lower motor neuron pathologies involve a very localized area? Which are the common lower motor pathologies we see and which involve a very localized area?
My poliomyelitis. Polymyelitis.
So, is it so localized as one hand? No, it's usually a generalized thing, right? What else? Syringomyelia. So will it be a acute event like this? One fine day suddenly? So where have you seen such localized weakness? In nerve root, peripheral nerve, muscle, NM junction, peripheral nerve. So peripheral nerve and one hand to get paralyzed by a peripheral nerve. What kind of an event should it be? Trauma. So this is not fitting into that at all, right? Then can it be muscle of one hand? So you are aware of localized muscular diseases, but they are not one hand. They are like limb girdle, right? So either pelvic girdle, shoulder girdle, whatever, but not one hand. So muscle disease is also out. So peripheral no one is whether it is a disease in evolution. So it's going to increase tomorrow or today evening or something. But again, go back to say whether it is not a monoplegia, whether it's a hemiplegia.
Consider hemiparesis. But how will we miss it on mere history? There could be a possibility that the baby child is walking, but the gait may not be normal. So check that whether there has been an abnormal gait, because it's in evolution. Now, when it's an abnormal gait, the question is it only on one side lesion that is causing that? And if it is so, then you might be able to see the gait where one side looks to be a little different than the normal side. Which could be the abnormal side if it's a hemiparesis in this child? Same side? Could it be the other side? Just give a thought. You are right. Mostly you are right. What is the cruciate hemiplegia? Have you heard the term cruciate hemiplegia? Cruciate hemiplegia is a lesion but the same side is the upper arm, but opposite side is the lower arm. So lower leg. So there could be a cross. We will be able to pick up a minimal abnormality in power only when we see the child walking. Until then, what is against the nerve lesion? This child is very young. So he won't know that tingling numbness is occur after an episode of fever. That is less likely because what happens after fever, as the fever disappears and some new symptoms come up, it's still proved otherwise. Could it be an anterior horn cell? So now guess on the history whether that one upper limb paresis is a symmetrically involved or asymmetrical. If it was asymmetrical, then it was like polio like anterior horn cell. How will you pick up on the history that it's one limb, but it's not symmetrically involved? It could be asymmetrical. With gives history that you have given, can you guess whether it was an entire limb involved or it could be only asymmetrical? If it's asymmetrical, call it a polio-like. You have given some clue to me. Just tell me on this. Read your history and you will know whether it is entire limb involved or only asymmetrical paresis. If it's asymmetrical, call it an anterior onset till proved otherwise.
Forearm, I said. Child was not able to move it.
If it's holding objects is problem, then that is it is also. You're right in thinking. So the point that I'm making is we could get into all these details. You have given if that is so, anterior onset is unlikely. Muscle is unlikely. Okay. The LM junction is unlikely. There is no pain. So root is unlikely. Therefore, then it must be another event after the immunological. So again, we start going. Let's just have a facial. What is your comment? Because that's the only nerve with different innervations, right? So should every hemiplegia have a facial also on the same side?
So love is usually involved with hemiparesis.
The answer is if it's an MCA stem itself, acute onset hemiparesis, there is a sensory involvement also, or only motor? It's an MCA stem. So that stem supplies even a sensory part of the cortex. So do you find sensory disturbances in an acute onset hemiplegia, or it's only motor?
Stereognosis, 2-point discrimination, tactile look.
That's a 3-year-old. But unless we do that, we will not find in an hemiplegia a sensory part. But that is only if the whole stem is involved. Otherwise, some tributaries are not involved, then that may not be there. So on examination, we'll be able to know. Now tell me, how will the examination tell me whether it is upper motor or lower motor neuron? That is simple question.
Reflexes, you will check. That's it.
Suppose we meet on examination upper motor neuron lesion. Now where are you? Just imagine that before we look at all that, let's discuss so that our concepts become more clear. Right? Suppose you have an upper motor neuron, one limb. Can it be so? Give a thought.
Depending upon the area which is supplied by that particular artery, even if only that small branch is blocked, then it could be only one.
But theoretically, yes. Practically, no. Okay. Why practically no? If it's a vascular, it's not only that area. And if it's a tumor, then it's slowly spreading again, not so localized. So again, if it is really monoplasia, monoparesis, then it has to be low motor neuron. Okay. And if it is low motor neuron, are we missing a hemiparesis? Yeah.
Soon to follow. Can that be there? Child may complain of right lower limb today. Tomorrow he has left lower limb also, and then within a few hours both the limbs are. Can it then? But for that, again, we are thinking of radicalitis. So if basically if you are not thinking of radicalitis because of absence of pain, then all this possible that the sequence may change, and sequence will make us keep in mind that it can change. But if our diagnosis is probably not radicalitis first, then that is also not like this. So we come. Can there be a subtle facial involvement which we have missed? Upper motor neuron, because that also can be the lower motor neuron, maybe not very common. But as sir said, lower motor neuron may be so subtle that we may have to pick it up either from the history or no, that order thoroughly to miss, not to miss a upper motor neuron. Can it be something simple like pain, scurvy, or some muscle, myalgia, or maybe bone injury? Out of question, all these things are related to pain. There is no pain, so absolutely not considered at all.
Is this neonatal history likely to be related in any way? Preterm, so must have got polycythemia. So whether that is related to this problem?
Congenital heart disease lead to like death.
You got neonatal pulmonary artery hypertension. So can this cause a thrombus which can get dislodged and blocked?
Unless there is shunt lesion, there is usually no thrombus formation.
Are you saying that there must have been a shunt, but we don't know? There's hypertrophy of the ventricle. So you are saying that at this point, we don't know whether there was a shunt lesion. Okay. Okay. Is there any history
On examination, child was febrile with heart rate of circumduction rate.
is very definite is circumduction. We are not so sure whether there is so much circumduction. What is very definite is that the foot is being put like this instead of heel first. So that is clear. Now focus on that. History we are not getting. चलो वापस जाओ बेटा एक बार जाओ उधर. Now further examination.
While walking, he seems to be trying to really just go off the round. Means he's not circumduction, but he wants to kind of lift this leg a little. Yeah, yeah, yeah. That's
Tone is decreased in right hand than left, right upper limb than
Usually you should try to see the tone at multiple joints. Okay. So, and the second thing, wrist joint and pronation supination. So you should look for that in the upper limb. And lower limbs,
hip joint and the abduction and
Just comment. Is there a difference? Obviously. Externally rotated right leg.
The left leg is externally rotated. The the tone is not in left side. The tone is slightly increased, and there is catch present uh, during flexion and extension at knee joint, dorsiflexion and extension at ankle, and normal movements at hip joint, adduction and abduction. Yes, sir, little. Uh, During extension and flexion in knee joint. Yes, yes, I.
During flexion, the power of the right lower limb is, at the hip joint is
Okay, you quickly tell us what are your positive findings.
I found the tone to be normal in both the limbs, and there was a slight decrease in power at knee joint on right side. I found it. Clean tone, slightly decreased. Right?
Technique has to be important. I remember as a joke, let me tell you that there was a grand failure in MBBS. He failed several times. Then he left. He went to the village and started practice, roaring practice, till his own friend became an examiner for MBBS. So he said, this is a good time to pass medicine. Only one subject remaining. So he went to him and said, you remember our friendship? This time you must pass me. Because he had put up MBBS into bracket F, which means fail. He said, I want to take that out. So he said, okay, now I'll give you a neurological case and I will tell the examiner, we'll ask him one or two questions. And if he answers, then we'll clear him out. So he said, I will ask you, what are the three causes of absent knee jerk? Okay. You answer this, we'll pass you. He tried to rehearse all that, but in general practice, he had jerk is absent. No? They said, excellent. What a great thing, isn't it? So the examiners were my team. They said, no book has given, but you know all that. So then the second thing came up. He said, knee in plaster. How will you take a knee jerk? Absent. Now he said, you, if you tell me the third one, see that. That's why I came here, definite spasticity. What about the plantar?
Plexus thing.
That is not right. So when you are using that pointed thing, what changes in the reflex? Pain comes in and therefore withdrawal comes in. And that is why it becomes flexor. So you should never use open that point and use. What is the word in the book? Stroke the lateral side of the sole. The word is जब पाँव सीधा रखो, कुछ नहीं करो, पाँव को ऐसे ही रखो। ना है नाम।
Use another method. Sometimes this doesn't work. Use another method. Come on, you are saying something.
We stroke the shin of the tibia.
So it doesn't matter. You know it. Let's see that. From about downward. No, no, yeah. No, you're right. Difficult. Sometimes in an examination, you may say, I'm right to do that, but I'm not sure. That's perfectly fine. He's evolving. I think when you were doing for increase stone, you have to have a speed. But when you use the force, you're not able to pick up that mild spasticity. So no force, but speed. It's a speed dependent, right? Velocity dependent.
Person. Marriage, resident of Vadala, Sheikh by community, Muslim by religion, immunized till death with no with history of NICU state. From meningitis or maybe transverse myelitis. Uh, we did basic investigations for
Or is. So what about meningitis? Why have you put meningitis as a DD?
it started with fever and
See, what I'm trying to let us understand, if anybody starts with fever and ends up with some neurological complaints, can we call it meningitis? What is our typical understanding of meningitis? What should be there to call it meningitis? So meningeal irritation in the form of not meningitis. What happens in between is very important. No? So there is no way you can give DD of meningitis. Where are we talking of the lesion? spinal cord. It has to be up. Very difficult to get a one-sided involvement. So that is also not to be given as a DD. Plus so many other spinal symptoms, right? And then lower limb was less involved compared to this. So all that is very difficult, right? Okay. And so did you get lower limb findings or no? Means you thought lower limb was normal?
I got lower limb weakness, right sided. Gait and all because of gait.
So therefore, your clinical diagnosis is what? Right hemiparesis, right? Now, again, when we talk of right hemiparesis, then typically, what is the most common lesion for a sudden onset hemiparesis? Pathology wise, vascular lesion, right? So, when you talk of demyelination, how do you differentiate a vascular lesion from a demyelination? Generally,
Will be more sudden, sometimes more gradual, progressive. Then,
Waxing, waning pattern, myelination.
Stability is later in demyelinating, whereas in vascular it is in the initial part.
what about unilateral, bilateral?
demyelination will be more generalized and multifocal, and stroke will be more on the one side.
Now, all these 4 or 5 points which you all said, this will fit in more with what? Vascular lesion. Okay.
Serum calcium is 10.1, phosphorus is 4.9, uric acid is 3.5, magnesium is 2.4. We did a LP for patient which showed TLC, total leukocyte count of 48 cells with polypredominance of 28 cells and lymphocytes of 20. Sugar was 50 mg per dl with corresponding HGT was 118. Culture sensitivity showed no growth. CBC picture of the child had HB of 11.6 with hematocrit of 38. A WBC count was 9.3 K with platelet count of 351. We did Coxsackie for the child, which turned out to be negative. And this gives us idea about anaerobic मतलब talk. MRI, we did a MRI brain of the child turned out, which was suggestive was there inferior end plate of C7 vertebral body above. The features were suggestive of demyelinating disorder. We have started the child on antibiotics, zone and vancomycin. First give, we have started the child on MPS also from today. Previously, he was on Dex.
I think all that we said to begin with was it was some immunological disorder triggered by some infection. So what kind of immunological disorder? It's not a primary infection at all. So the question is, do you have any evidence of inflammation in the meninges? I don't think that those cells and little protein means any to consider a classical hemiparesis looks a little unusual presentation. The vascular, it is either thrombosis, embolism, hemorrhage, vasculospasm, or vasculitis. It's only in vasculitis that thrombotic event who has no risk factors to cause thrombosis. That might put us to say clinician falls short of a final diagnosis. Because on both sides, if it is vascular, then we would have not expected fever triggering that unless there was a risk involved, a thrombotic risk, which this child obviously doesn't have. And if you consider an immune mediated demyelination, then there are some unusual feature. So we know that this is something unusual. Then we try to decide which is least unusual. If it's a hemiparesis, he should not have such a kind of an asymmetrical involvement. So that's another point against it being a thrombotic itinerant. Now, this is retrospective. All that we would have said to begin see, every time when there is some dissimilarities in your anticipation, when your final diagnosis is made by investigation, you try to go back and say, could I have thought of this? Like I did not think about this. We might recall every time that yes, we have seen ones like this. So I think that's the
hemiparesis on one side and said we understood the principle if there's a weakness on the one side, then there has to be a weakness on the other side also. So mono has to recover. But if you go to such a patchy lesion, and patchy also on one side also it has been patchy, the upper limb or not. We don't know it. On the lower limb side, left side also there may be some patchy lesion which you may see on MRI. And maybe on the left side we got it, but we were so much carried away by the right. Only then when we go wrong, we go hemiparesis and patchy and demyelination.
Good evening. 7-year-old female child, first by birth order, born out of.
Hello, Rajesh, can you hear us?
Yeah, we can hear
Rajesh,
you.
can Rajesh, the sound is very, very interrupted. After every two sentences, we cannot hear anything. And then again, it comes back. So we missed a lot of the last case.
Acha. We've just checked all the connections again.
Okay.
Looks okay. Let's see this now in the second case. Yeah.
Yeah, just a comment on the earlier case. Could it be Moya Moya? Just the beginning of.
So I'll just summarize what we discussed. Piece, we did
Yeah.
start saying that it looked more vascular clinically.
Yeah.
Lot of disparity between the degree of weakness of the upper limb and lower limb,
Okay.
which is odd for a hemi, not like 5 and we realize that probably there are subtle findings on both sides, which then explains the demyelination, right? So,
Okay.
so
Yeah.
once we move from vascular to demyelination, fever. So these are all the points, but of course they are retrospective. We probably just got carried away with the monoplegia to say that we are looking for a hemiplegia. We did get some hemiparesis and then we went on to calling it a vascular.
Okay.
Yeah.
Rajesh, even this reply which you made was interrupted, but that's okay. We got the gist of it.
Okay. Okay.
Thank you. Thank you.
7-year-old female child, first by birth order, born out of non-consanguineous marriage, hailing from and resident of UP, Chamarbai community, informant being mother, came with the complaints of fever 1 week back for 3 days, vomiting since 2 days, and abdominal pain since 2 days. Child was apparently all right 1 week back when she developed fever, mild to moderate grade, undocumented, intermittent, These medications associated with chills and not associated with any rash. For this complaint, child was taken to local clinic, received oral medications for 2 days. Then child was afebrile for 3 days. Then she developed vomiting 4 to 5 episodes per day for 2 days, non-bilious, non-projectile, more after meals, contained food particles, and not associated with any blood. Associated with abdominal pain in periumbilical region, intermittent dull aching, not associated with any aggravating or relieving factors. After 2 days, child was preferring to sleep, irritability, screaming intermittently, but was obeying commands and responding verbally. After some hours of altered behavior, child had one episode of paroxysmal event in form of uploading of eyeball, not associated with chronic movements of bladder and bowel incontinence, lasted for 2 to 3 minutes, settled on its own and followed by PID for 30 minutes. History of fatigue in bilateral frontal region, which was non-radiating. History of decreased activity since 2 days. History of decreased oral intake since 2 days. There was history of travel from UP to Mumbai 2 weeks back. History of right eyelid twitching present on the next day. Mother also noticed deviation of left eye to medial side since 2 days. There was no history of neck pain, photophobia, pupillological deficits, loss of power. No history of any swallowing pupillological deficits, loss of power. No history of any swallowing difficulties, headache or vision, deviation of mouth. No history of seizure disorder or previous similar episodes. No history of jaundice, cough, cold, increased work of breathing, no history of looseness and coughs or coughs contact. There was no history of any past admissions. ANC is uneventful. Birth is full-term normal and delivery. Cried immediately after birth weight of 3.5 kgs. No history of anistia or neonatal jaundice. Immunized till date. Developmentally normal. Studies in second class. Died.
Okay. So now tell us what is your interpretation of the 3 days and then vomiting and abdominal pain.
And could be prodromal symptoms.
So in a viral illness which has multi-system involvement, three 3 days and then develop vomiting 4 or 5 times. So what does that mean? So for 1 minute, take this story away. If any of your viral fevers start getting fourth, fifth day, fever goes down, vomiting starts, abdominal pain, it is typical dengue capillary. Then it's some kind of a complication. That is one important. Second, can this be dengue? Going by this story. Could be.
Dengue, the textbook statement is abrupt onset of very high fever. In situation other than this, then it's not possible. So abrupt onset of very high fever with headache, body ache, and backache is likely to be dengue. Then the
else which is odd. We started the discussion saying that vomiting, abdominal pain, we all said typical of dengue. So why is this not typical of dengue? So if the gap is really 3 days, which is correct, if your history is correct, and these are the odd points, right?
What's the cause of abdominal pain in dengue? Question.
Could be due to dengue hepatitis.
Dengue hepatitis.
Where were we?
Hello, can you hear us?
Yes, ma'am. You are audible. You are audible.
Now you're audible after about 5 minutes.
Yes, you are audible now.
बोल बोल आगे बोल जो भी बोलना है.
After 2 days, screaming intermittently but was obeying commands and responding verbally. After some hours of altered behavior, child had one episode of paroxysmal malabsorption. Radiating. History of decreased activity since 2 days. History of decreased oral intake since 2 days. There was history of travel from UP to Mumbai 2 weeks back. History of right eyelid twitching present on the next day. Mother also noticed deviation of left eye to medial side since 2 days.
The interpretation of all this.
This altered Deepak. So am I audible?
Yes. Yes, you were audible that time, but not now.
No, it's not moving. Not okay.
But carry on, please.
Then there's no history of neck pain. Past.
Word.
Past, no history of any past admission, ANC, uneventful birth, normal, immunized till date. Developmentally normal.
So after history, what's your provisional diagnosis?
7-year-old female with history of fever, vomiting, headache with altered behavior and seizure, with history of travel, abnormal eye movement, and left eye deviation to medial side. In a birth and developmentally normal, immunized till date child. It's probably a
Points for or against all three. And speak little slower.
acute viral meningoencephalitis. There's a history of fever and vomiting on the abdominal pain, altered behavior, and meningoencephalitis will be the generalized involvement of the brain in infection. That's how. Then autoimmune.
So as we discussed just now, that while your acute viral meningoencephalitis technically is right, but we just discussed that fever has gone pehle and then you are getting the meningoencephalitis after 3-4 days, 5 days break. So that is against acute viral meningoencephalitis. In acute viral meningoencephalitis, everything should happen together, correct? So that is against. Now what about autoimmune? What is for and if anything against?
In favor
Encephalopathy.
against this very short course autoimmune थोड़ा long course.
So behavior change is, you're right that it's a feature of autoimmune, but basically behavior change, all that is telling you that, right? It has happened after a febrile illness, so that also is fitting in as a immunological phenomenon. So now about short and long. So many autoimmune are little subacute chronic types. They happen slowly. But at the same time, there are many which happen in this duration also. So there is a fairly strong chance of it being a autoimmune following that whatever viral illness. What about TB? Or anything that comes to anybody's mind.
It's been a chronic course.
Vomiting after gluten consistent eating.
Yeah, but we discussed that that didn't fit into anything, so that's not a very strong point. What about the neurological part? Focus on the neurological part and tell us you've seen whatever 2, 3, 5 ppms. What do they have in neurology and what is there in neurology here? What does your usual TPM have?
Focal deficits.
Focal deficits, very good. Then
I think in an older child, a TBM would have a presentation of a raised ICT because of TB meningoencephalitis. In a younger child, it could be predominantly encephalopathy. But in an older child, so now here, you said about screaming. Okay, so child has been irritable. Now, that irritability points out to me that possibly there is a raised ICP. Now, if that is there, what is the TBM pathologically? One is an increased intracranial pressure. Well, irritability could be in favor of that. The second is encephalopathy. Yes, it is there. But the third important is focality. TB encephalitis and vasculitis. Vasculitis brings in focality. Now, cover TBM as well. Now, what we would have clearly got is if the 7-year-old is not doing too well, okay, some story in the past. And you might find some signs in the lower limbs because of hydrocephalus, because the pyramidal tract going to the lower limbs are compressed. So possibly we will know on clinical examination whether we are on TBM and encephalopathy or encephalopathy with raised and there's sixnopalsy. So then I would favor a TBM as well.
On examination, febrile, pulse rate of 100 per minute, regular in rhythm, good volume, bilateral equal on both sides, no rate of delay or rate of humoral delay. RR of 26 per minute, regular rhythm, saturation maintained, peripheral versus ventral extremities warm. PP was at 5th centile on presentation. I had to multiple rest no new kidneys markers and this is normal.
Go and touch.
That to do in the disconnect.
Environmental is less irritable. Renal of examination first was not cooperative. Second, bilateral pupils reacted to light perception to light was present there. Left lateral rectus palsy, corneal with name, uvula was central position, gag reflex present, tongue is normal. Motor examination, bulk is equal on both the sides, tone normal in all 4 limbs, power was more than 3/5. A system exam RS entry equal and clear. A 7-year-old female with history of fever, vomiting, headache with altered sensorium and seizure, with history of travel with abnormal eye movements with left lateral rectus palsy, probably a case of acute febrile encephalopathy with raised ICT to rule out acute viral.
You should have stressed on fundus or even macerons. Okay, all that. But whatever has been said, possibly it's not a big deal in encephalitis because we did not get any of that. Acute viral encephalitis we have already discussed, not fitting in at all. Then also we discussed unlikely. Okay, so we may be left behind again with autoimmune encephalitis. Okay, so to my mind, 6 now is little unusual thing. There is so much of raised ICP. Okay, you will have more of encephalopathy, drowsiness, and consciousness. But why so much of the 6 now palsy coming up with raised ICP? Encephalitis, there is not an obstruction that is causing large pressure change, but just brain cell much seems fictional palsy coming up in a viral encephalitis because of raised ICP, or for that matter in autoimmune encephalitis. So again, there are pluses and minuses. We will learn once the final diagnosis is done what is unusual in this child, right?
Investigations. There was a dropping trend of platelets that is significant in CBC and OLD was negative and PSMP negative. Machine is not working. LFT is normal. ESR is 4 mm per hour only.
Taking serology
OLD is negative.
and
The
hemoglobin is falling.
platelet count is falling.
Even hemoglobin is.
थोड़ा 9.6. And anti-edema measures with 3% insulin Dexa, antibiotic zone vanco, and acyclovir.
After anti-edema, how much
Since
has happened?
3 days.
Better.
Sensorium has improved, but lateral rectus pulse is still there. Just not fitting. Fundus is NAD.
I think one thing is certain, there is a meningeal inflammation. The 150 cells. Okay. And this looks like not an acute one because you are mostly lymphocytes. To that extent, you have a chronic meningeal inflammation. That must be known. Now, in a typical meningitis, there is not an immune process. In the meninges is infection till proved otherwise. So to me, this is definitely a meningeal inflammation. Now, I don't know whether in an autoimmune encephalitis there is a meningeal inflammation. Okay. So that we will have to check, but possibly not. And if that is so, then I will still search the cause of a chronic infection in this cell. Now the question is it chronic infection not all viral infection complicate. I'll give you a simple example. Viral hepatitis A. You may start with fever, nausea, vomiting. Fever may disappear, the jaundice may go on. Even the hepatitis may increase. So to me, a viral infection may not continue with fever, but to call it a viral encephalitis, the fever should have continued as well. Because, and this is more of meningitis. Could it be viral meningitis? The answer is no. There are viruses which cause chronic viral meningitis. So to me, we must further find out the etiology of this meningitis. Inflammatory response. What's the protein like there?
Sir, the machine is not working.
Such meningitis. So we may have to look at something of that kind. Can a leptospira do that? Fever is not suggestive of that at all. But unusual infection causing meningitis. And not only meningitis, meningoencephalitis.
Sir, the fever is not there, so I thought leptospira will
No,
be.
I agree.
Yeah. And the other point, a lesion rather than a marker of raised ICP. Means whether it's a nerve involvement, it's very uncommon, but
Chronic infective meningitis, in which the fever is not the predominant feature. And I think meningitis, so that is unlikely. But then imagine what is TB meningoencephalitis, would something be stimulated by a chronic viral meningoencephalitis? I have no idea which virus could do that. An ID specialist could possibly would have told us what all viruses can do that. We have no obvious idea, we have not seen much. So I think this cell needs further workup on maybe viruses, etc., more than bacteria, more than TB. Okay. And I think that's the way I would look at it.
So like the previous case,
Yes, sir.
history in a pause and then suddenly coming up. So I was more in favor of any immunological disorder. Only point I thought not so patchy. Some part is involved here, some part may involved here. That may favor either or autoimmune both. But there is definitely a big cell. Even if it is not the sign, we can send to a virologist center because that will clinch the diagnosis.
MRI is done.
MRI is done today.
Okay.
And we have sent CSF gene expert. We have sent CSF gene expert and sputum gene expert also. After MRI, we plan for CSF antibodies or
Symptom as in you're not coughing, no?
GL.
MRI department is just by the side.
No, not. Okay.
Occasionally, somebody has told us, oh, last time we proved this. But otherwise, make it a point. Okay, that's the only way we all will learn.
Could this be partially treated by
Story was not like a bacterial meningitis. The first story would have been headache, irritability, then vomiting. Second, so probably not. But what he's trying to say is that a chronic meningitis may be partially treated bacterial meningitis, which is true, but probably not this.
And for that meningitis process to be suppressed, the initial therapy has to be relatively aggressive. Oral antibiotic given as OPD patient to suppress the acute process and give rise to chronic. First two they're more often than not.
Okay, so we'll stop here. Any comments or questions from the online audience?
Rajesh,
Yes.
thank you very much for both cases. In the second case, I thought whether multiplex PCR on the meningeal fluid was done.
No, closed. Or my phone also has them. All these have extra mics. So suppose we use them, maybe they'll audience will improve. Yeah, audition. बाद में करके देखते हैं.
इधर है.
इसका mic चालू करो. Because see, all of us, if we use our phones.
माइक मतलब ऑडियो तो चालू ही है.
इसका there's a mic on.
I recall only once I have seen a case of melioidosis. And I had never known that. And I had said it looks like a TB.
The mic is on.
But it was not. And then I looked at the literature that time, and it had clearly said that melioidosis exactly looks like a TBL. But it needs a long-term other antibiotics, not an anti-TB drugs. So I'm sure there must be many other infective agents which behave like a chronic meningoencephalitis, of which we are not. And that gave an ID specialist to say, can we look at the melioidosis? We had never known that in a dirty water you swim and you get melioidosis. So we are so much ignorant about many such unusual things, yes.
Oh, done. I want to tell them two research stories. Is it okay?
ये डिस्कनेक्ट करो यहाँ.
Correct.
Yeah, so we'll log off.